My name's Professor Jeremy Chapman. I'm a professor at the University of Sydney and at Westmead Hospital. My background is as a nephrologist, working as an expert advisor to the World Health Organization. I've been involved in discussing with a number of countries the role of legislation and components of organ donation regulation. And I'm delighted to be able to share with you in Laos the fruits of that process. If one is undertaking living donor kidney transplantation, these are the processes that are required. A living donor requires a donor assessment, a donor medical risk assessment in relation to transfer of disease to a recipient, a cross-match between the donor and recipient to test for tissue compatibility, followed by surgical retrieval from the donor and surgical transplant in the transplant facility, and then transplant follow-up recorded in a transplant registry. It is a relatively straightforward process. If you add deceased donation to a transplant program in a country, you add the complexity of needing to confirm the diagnosis of death. Donor medical risk assessment is the same, cross-match is the same, but it has to take place urgently. Surgical retrieval is somewhat different, but with the same outcome. On this occasion, 2 kidneys retrieved usually. And then organ allocation is the mechanism that must be undertaken to ensure that you transplant appropriately, fairly, and transparently. Transplant follow-up is the same, and the transplant registry should be able to tie up the organs retrieved to the transplanted patients and record the outcomes. So that's the process. You can indeed add tissue banking, cornea, other tissues, and tissue utilization, adding further to the complexity. So the next question that arises for a national legislature is, what are the principles that we are going to espouse in creating that legislation? And the points that I put here are things that you need to make decisions about. Compatibility with the World Health Organization guiding principles. They were signed on in 2010, most recently, at the World Health Assembly. I do not recall if your minister was there. The second set of issues you need to consider is the extent of inclusion of all medical products of human origin, and I will discuss that. The basis of consent must emanate both from your own environment and community and from the tried and true international bases for consent to donate after death. And that brings us to needing to define death. And I will take you through each of these issues. So this is a diagram by a German artist, Escher. And one needs to stare at this diagram for some time to see both an angel in white and a devil in black. And they are intertwined. And I show you this because transplantation, unfortunately, comes intertwined between good, the saving of human life, and bad, the corruption, the commercialization of the human body, and some of the terrible consequences that can flow from that. Separating those two out, controlling one, and allowing the other to flourish is a critical component of your legislative environment. Failure to legislate appropriately and regulate appropriately allows the black devil to flourish and the white angel to be diminished. So we set about, with the Transplantation Society and the International Society of Nephrology, establishing some professional principles for doctors like me, and like the doctors that you have, who will undertake these procedures. They are our principles. And the World Health Organization set about establishing national principles at an international level. Principles at the World Health Organization level, encouraging member states to adopt certain principles. And those sets of documents are available and visible and readable. If we look at the World Health Assembly's decision, they have 11 principles. And I've added 10 and 11 in red because they were added to the original 9 principles which were adopted in 1991 by the World Health Assembly. So the revision added principles on quality, safety, and efficacy of the procedures, and transparency, but personal confidentiality. And if one lines them up against the process from donor to recipient, one sees that there are principles governing most aspects of the critical components of organ donation and transplantation. And if you look at guiding principle 10 and 11, they are long-term principles added to ensure outcomes are appropriate and that there is quality and safety of the procedures and products. Transparency is a critical component of transplant programs, and the World Health Organization collects data from around the world, visible in the Global Observatory on Donation and Transplantation, on transplant rates, transplant outcomes, origins of donation, outcomes of transplantation. It's a critical component of ensuring that your national program holds back the devil and allows the angel to flourish. I mentioned that there is a need in the definition of your legislation to ensure that you understand what you are including in this legislation and what you are not. These are all medical products of human origin. We can take simple ones: blood, plasma, cornea, kidney transplant. But there are also gametes, embryos, human reproductive cells. There are hematopoietic stem cells, bone marrow transplants. And then we are moving into advanced stem cell therapies. And at the other end, we're moving into human-derived drugs, where some of the components of donated human material are used to derive drugs or other devices in dentistry, for example. So how much is covered varies around the world. Many nations will have different legislation for blood and plasma, for example, but very similar legislation for organ transplant, bone marrow transplant, and tissue transplant, and yet again, separate legislative environments for human reproductive organs. Death is critical to understand, to define, to be able to recognize, and for the community to accept. The global view is that the function of the brain is irreplaceable. and that death occurs when the brain no longer functions on a permanent basis. The definition of irreversible coma was defined here back in the 1960s through an ad hoc committee of Harvard Medical School, determining how to progress with organ donation within the environment of having probably 10 years of successful or moderately successful living donor transplantation up to that point, and the need to move to better definition of potential deceased organ donors. And the laws that were ultimately formulated, this is in the US, but they are applicable globally, states that an individual who's sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. So either the heart and respiration stop, or the brain ceases to function permanently. Those two definitions are now coming together as we understand that the cessation of the circulation that is critical is actually the circulation of the brain. You could have circulation in your little finger and you wouldn't be alive if you have permanent, irreversible cessation of circulation to the brain. So it brings us back to a single common determinant of death, which is permanent, irreversible cessation of the function of the brain. This can be looked at in a number of ways: loss of capacity for consciousness, perception, loss of brainstem functions, unable to breathe spontaneously, and loss of a number of reflexes. And of course, it has to be permanent. A loss of function that will not resume spontaneously. In other words, when the heart stopped and you're not intending to restart it, how long before you know that that heart will never start again? How can you see the loss of function to the brain? This is the loss of blood shown on a nuclear scan. And so we come from a, if you like, philosophical definition of death to the hard medical definition of death. And that's not best placed in legislation. I'll come to where it has to be done. So I've assisted a couple of countries in designing the way that their human organ, cell, and tissue laws and regulations work. And it's very clear that they interact with all sorts of other legal frameworks that you have. Your ownership and gift laws, your therapeutic goods laws, private healthcare laws and regulations, who is allowed to do such procedures, customs and excise laws and regulations. What may you import? Can you import blood? Could you import an organ? What happens if you import an organ? The consent framework. And then, of course, into definition of nationality. Who are the people of your country who may be transplanted in your country, who may donate in your country? I hesitate to put this up, but it is a critical element that you need to think through. Who does the community trust? Because it is in the end the community that must trust. Otherwise they won't donate. It's very simple. So Who do they trust? Ministers of Health and Justice? Society leaders, however you define them? The Ministry of Health? Hospital administrators? Committees? Ethics committees, for example? Doctors? Do they trust doctors? Do they trust committees of doctors? Do they need to be independent doctors? Nothing to do with the transplant program. The capacity for money to change hands from the wealthy to anybody involved in allocation and little to the poor is unparalleled in this field. And it needs to be guarded, or you will end up with no transplant program. Just a small little commercial enterprise in the corner of some private hospital making money for a few doctors and not solving community-wide healthcare problems through transplantation. I can tell you where we are in Australia and New Zealand over some of these issues. Legally, we've had accepted legislation by each of our states from 1978, legislation that has been accepted and endorsed by all religious leaders in the country. So we have multiple states and we have multiple legislations because this issue is legislated at each state level. They're all very slightly different. Most of those differences don't matter. There are a couple of practical issues which do matter. Makes it a little complicated, but it is legislated off a common basis. It is agreed that whole brain death is the definition of death. This has a high degree of medical support. For example, here, you can see that the definition of death, irreversible cessation of all function of the brain of the person. And this reappears in different definitions in different states. I've just simply chosen South Australia and I think New South Wales in this example. So how do you do that? How do you translate that very simple principle, which is enshrined in law, into clinical practice? And the answer is that we have used the Australia and New Zealand Intensive Care Society, a professional group, intensivists, not involved in transplantation, but critically engaged in the management of intensive care units with an absolute need to determine death for patients on ventilators in intensive care units. And so they have created guidelines. They've been revised a couple of times as more knowledge has come and as more and better tests have been available and as new support systems have become available. The medical definitions have had to grow with the changing clinical environment. And that is why you can't legislate it, because you'll be re-legislating it in 3 or 4 years' time. But you do have to define somebody independent who makes that medical definition for you. You can use guidelines from around the world. There are 2 or 3 well-known guidelines. This is one of them. And your country is perfectly at liberty to say, we will define death medically as that which is defined by European, North American, Australian medical practitioners. You can define it by your own medical practitioners. It's a lot of work, and you've already got it ready-made. So in Australia, that death has to be determined by 2 medical practitioners using clinical testing and imaging. They will have local hospital guidelines as to which practitioners. What is absolutely critical is that those practitioners have no conflicts of interest. They have no interest, engagement, involvement, or employment in transplantation. And we have an organ and tissue authority, which is a government-driven authority that runs the protocols for organ donation. And with this process, we have a high degree of community acceptance, despite the fact there's really quite little understanding of brain death. What we have is an opt-in system. In other words, the donor prior to death or the family after death must consent to organ donation. So if we then look at the differences in deceased organ donation and living donation, there are a number of boxes here. The green boxes are medical protocols. They have to be medical protocols. They change as medical knowledge changes. You need doctors and laboratories to make those decisions. You need surgeons and an operating theatre to undertake the retrievals, similarly to transplants. And you need doctors and nurses to undertake the follow-up. But in grey are the things where the ministry needs to be involved. With living donation, many Asian countries have authorising committees, ethics review committees that determine and approve the relationship between the donor and the recipient, or more importantly, disapprove it when they suspect commercialism, the payment of the donor for their organ. My strong advice is to have one national waiting list. This is currently a huge debate in a couple of Asian countries, Sri Lanka, for example. One national waiting list provides transparency, clarity, and equity. People can see what's happening. Kidneys are allocated to people. They're not allocated to doctors and hospitals. They're allocated to people who need a transplant on a waiting list. And how one runs the allocation system beyond that then can be a subject of public debate and medical engagement. Who should get a kidney? But it is important that there is a waiting list and that it is not Dr. X's waiting list where the patients pay to get onto his waiting list and pay even more to get to the top of his waiting list. Transplants in most countries only occur in ministry-accredited transplant facilities. Strongly advise that. Organ allocation and the national allocation program protocols I've just discussed. But another important factor is a transplant registry and follow-up, understanding how many of these procedures have happened, who has been transplanted, where they have been transplanted, and then their outcomes is the only way that you will continue to improve what is still a complicated and difficult and potentially very dangerous set of procedures for the patients. I hope this brief tour through organ allocation and backwards through the various legislative and regulatory principles that are needed has helped you, and I'm happy to be involved and engaged with any conversation that would help you. Thank you for the opportunity to talk to you.